Welcome to the presentation of the GLASS report 2021. I am Barbara Tornimbene. I'm a technical officer in the Surveillance, Prevention and Control Department of the WHO AMR division. This year, the reports aim at describing the status of development of the GLASS activities, at highlighting the new technical module on antimicrobial consumption surveillance, GLASS AMC. It summarized the results of the 2020 AMR and AMC data call from participating country and their data limitation, and also the WHO AMR related activities globally and regionally. The Global Antimicrobial Resistance and New Surveillance System, GLASS, was launched by the World Health Organization in 2015 to foster surveillance of AMR, AMC, and AMU globally, so to inform strategies to contain AMR. GLASS provides a standardized approach from the collection, analysis, interpretation, and dissemination of data relating to AMR. And it's designed to be implemented in a 5-year cycle, followed by revision and further development based on lessons learned and best practices. And compared to the first year, where GLASS was basically focusing only on the routine surveillance of AMR, now the GLASS environment is comprised by a number of technical modules. Precisely, we have 8 technical modules divided in 3 silos. The first one is the routine data surveillance, which comprise the antimicrobial resistance and antimicrobial consumption routine data surveillance module. We also have focus surveillance, which is aimed at generating information on specific purposes. And here we have the emerging antimicrobial resistance reporting module, or GLASS here, the enhanced gonorrhea surveillance, or EGAS module, and the candida species AMR surveillance, or GLASS contract module. We have also developed a number of surveys and studies to estimate burden and drivers of AMR based on country needs. And these are the One Health AMR surveillance, or One Health project, which is the tricycle also called project. The point prevalence survey methodology for antibiotic use in hospital, and finally the GLASS methodology for estimating attributable mortality due to AMR. GLASS is also the source of the new Sustainable Development Goal AMR indicator, which is the percentage of bloodstream infection due to methicillin-resistant Staphylococcus aureus, MRSA, and Escherichia coli resistant to third-generation cephalosporin among patients seeking care whose blood samples are taken and tested for species identification and antimicrobial susceptibility testing. As of April 2021, 109 countries were enrolled to GLASS. I use the past tense because now we have reached around number of 110 as in June 2021. But in April, we still had 107 countries enrolled in the GLASS module and 19 countries enrolled in the GLASS AMC module. And in this map, you can see I've shown the country in blues. In blue are the countries that are enrolled for both modules. Then we have in purple the country enrolled in the AMR module, and in orange the country enrolled only in the AMC module. So in terms of GLASS AMC highlights, GLASS AMC provides a common, standardized set of methodologies for measuring and reporting the consumption of antimicrobial medicine at country, regional, and global levels. Antimicrobial consumption is defined as the quantity of antimicrobials used by a population in a specific setting during a specific period of time. And these data are measured from aggregated data sources such as import or wholesaler data, aggregated health insurance data, hospital pharmacy dispensing, or procurement database at the healthcare facility level. And this information is considered as a proxy estimate of antimicrobial use. This year, we had 15 countries enrolled in the AMC module by the end of December 2020. And they reported information on the structure of the national AMC surveillance system, specifically on coordination, structure, data availability and use, and the coverage and granularity of the national AMC surveillance system. Now, this was really the first attempt to monitor national AMC surveillance implementation globally. And in a way, it allowed to test the proposed AMC tools and set a benchmark number to monitor the implementation of national AMC surveillance system over time among the reporting country. And the second AMC data call has opened already in 2021, and new data will come for the report next year. In terms of highlights for GLAS AMR, well, by the end of the AMR data call on the 31st August 2020, we had 94 enrolled countries, of which 82 actually provided data to us. You can see here on the right, there is a map that diversify based on the color, the type of data that the country have reported to us. I think in the dotted country have reported only information on the status of the national surveillance system. These were 12 countries. Then we had 4 countries reporting only AMR rates, and then we had 66 countries reporting both the information on the status of their national surveillance system and AMR rates, and these are colored in purple. So in total, we had 70 countries reporting AMR rates. And you can see here the GLAS development through the GLAS 4 data calls in terms of number of sites, surveillance sites that were reporting to GLAS, and number of patients with confirmed infection for which we received results. And in 2007, we started with 22 countries reporting AMR data with 729 surveillance sites and roughly results from 500,000 infected patients, up to this year where we have 70 countries reporting to us with about 25,000 surveillance sites for more than 3 million patients with confirmed infection for which we received data. And I put below the link to the WHO Global Health Observatory page, where you can find the visualization of the data reported at national and the summary at global level, and also the summary of the SDG indicator. Talking about SDG indicator, the reported rates for bloodstream infection caused by E. coli resistant to third generation cephalosporin were quite high. The median rate was almost 37%. Worryingly, when we have stratified the data by country income origin, we have noticed that there is a high level of resistance in low middle income countries. However, if you see at the bottom of this graph, we also report the number of countries submitting data for a specific indicator and the number of patients with AST result of which we extrapolate this data. And here we can see that there is a huge discrepancy of number of tested patients between low middle income country and high income country. And not only that can bias the data, but also suggest a very different, probably a very different type of access to care in different income levels. Here also we have the graph for bloodstream infection caused by MRSA. The overall median resistance was around 25%, but again, we see higher rates in low and middle income country, and for sure these results need to be investigated to understand if are related to biases linked to the data, or if this really is the reality of a higher burden of this type of infection in low and middle income countries. Also, interestingly, we saw a quite high rate of resistance reported in pathogen causing bloodstream infection against last resort antimicrobial medicines such as carbapenems. I'm showing here the reported rates for resistance rate for bloodstream infection caused by Acinetobacter species. You can see on the far right the 3 antibiotics belonging to the carbapenem class, and you can see that all of them show quite high rates of resistance. In general, the median carbapenem resistance rate for the whole class for BSI caused by Acinetobacter species was almost 66%. Equally disturbing is the finding of high rates of resistance of community origin infection for urinary tract infection caused by Enterobacteriales. I only put E. coli, but we have the same picture for Klebsiella pneumoniae. And here you can see the graph for the resistant to ciprofloxacin, which should not be used as a first-line treatment, and still it's quite high in the community with an overall median rate of resistance of 25%. Again, quite worryingly, the eye rates of urinary tract infection caused by Enterobacteriales resistant to cotrimotazole, which is first-line drugs, and this could, in theory, preclude empirical treatment. And here we can see that for both E. coli and Klebsiella pneumoniae, we have median resistance rates which go from 50% to 43%. Finally, high level of resistant first-line empirical treatment in Neisseria gonorrhea were reported. Here on the right, we can see quite high resistance rate for ceftriaxone and azithromycin. Unfortunately, we cannot identify multi-drug resistance for both antimicrobials, but we know that many countries have reported more than 5% of resistance for these antibiotics. And this suggests that the empirical treatment guidelines might need to change in relation of the reported data or the data that are found captured by the surveillance of the countries. Now, of course, there are constraints when using data that are generated by routine surveillance at national level. We know that the country are at different stage of development of the national AMR surveillance system. We've seen very varied clinical and diagnostic capacity. We are very much aware that data completeness and national representative needs require special attention, and we know that precision and representative of surveillance may be heavily impacted by convenience sampling or other bias that are intrinsic to surveillance system based on routine diagnostic sampling. Moreover, data aggregation at national level does not allow for analysis of multi-drug resistant distribution, and for this reason, from the next step, GLAS will offer the country the opportunity to actually submit the data in a line listed format, which will allow for much enhanced analytical capacity and approach to identify trends and drivers using the data reported. In terms of highlights for the focus surveillance, the enhanced gonococcal antimicrobial surveillance program has now been piloted for 2 years in the Philippines and Thailand, and it's now in its initial implementation phase in Cambodia. The pilot has shown that actually the EGASP protocol is a sustainable methodology, and very importantly, it allows to detect emerging AMR for gonorrhea, monitor trends reactively, and identify repeated gonorrhea infection and possible treatment failure. And the general protocol has finally been published in 2021, and you can find it through the link that I put at the end of the slide. Those highlights were studies and surveys. Also, the One Health, the Global Tricycle Surveillance protocol was published this year. You can see the link at the bottom of the slides. The tricycle, the One Health module for GLAS is an integrated multi-sectoral surveillance system based on the ESBL E. coli tricycle project, where the ESBL E. coli has been chosen as a common indicator to be detected across human sample, poultry, and water bodies, specifically sewage, market runoff, and river sites in urban sites. You can see below that the protocol, the project has been piloted in a number of countries in the last few years in 4 of the WHO region, and the experience gathered through the piloting has informed the publication of the final GLAS protocol, the final protocol. So conclusion and way forward. Well, despite COVID-19, the number of countries reporting AMR data has actually increased this year, signaling that AMR is still a very high priority in country public health agenda. As you have seen from the description of the technical module, GLAS has become a multifaceted system which integrates key AMR surveillance activities aimed at shedding light on the intricate epidemiology of emerging AMR. The implementation of AMR and AMC surveillance core components by countries show progress throughout the year, particularly in low-income country and low-middle-income country. And you can find the graph representing this in the report and in the Global Health Observatory page. And finally, the focused surveillance and studies will definitely contribute to shed light on AMR burden and related drivers, including, as we have seen now, the AMR in the human, animal, and environment ecosystem. I mean, interestingly, most countries reported high rates of AMR in bloodstream, urinary, gastroenteric, and genital infection. But more research is required to ascertain what is really driving this data, and more information is needed about the population group from which the data have come. In this regard, glass antimicrobial consumption surveillance will be actually key to identify AMR drivers, even more now in view of the documented COVID-related antibiotic use. And the participation in glass has fostered countries' capacity to develop their national AMR, AMU, AMC surveillance system, as we have seen through the 4 years progression of the AMR module. Way forward. Well, the third high-level technical consultation and meeting on surveillance of antimicrobial resistant immune for concerted action took place in April this year. The consultation was organized by the governments of the Republic of Korea and Sweden, and it helped outlining the next step for glass development and implementation. Countries enrolled and not enrolled in glass participating in the event, together with academia, technical partners, internal partners, and so on. Overall, we had the feedback from 88 countries, and it was agreed that complementary approach, such as survey, are needed to address the data limitation and ensure all countries will be able to generate representative quality data. But moreover, the next step for glass were defined, and glass will focus at improving the use of surveillance data. This is at global, national, and local level, improving data representative equality, enhance laboratory capacity in low-middle income countries, assess the burden of AMR, expand AMR and AMU-MC surveillance, and facilitate the AMR surveillance linkages between the human, animal, and environmental sector. Finally, glass is supported by a very large number of collaborators. This report described the 2019 AMR-related activities of WHO HIV, tuberculosis, and malaria departments and WHO regional offices. Their continuous input and vast number of activities provide massive support to countries and valuable guidance to glass development and to AMR control globally. Glass also continues benefiting from the expertise of WHO AMR surveillance and quality assessment collaborating center network and the backing of regional AMR and AMC surveillance network, which represent important pillars for advancing AMR surveillance globally. So finally, together with partners, the WHO 3-level network plays a key role in promoting peer support for capacity building and identify ways to overcome difficult on AMR surveillance. And with this, we thank you. I thank you for your attention, and I hope you will enjoy the new, fresh GLASS report 2021. Thank you.